This is Health Matters, a podcast from Mayo Clinic where we discuss the latest medical advice, news, and research to help you live a happier and healthier life. My name is Kristen Meinzer. I'm a writer and journalist. And this episode, we're bringing you the first in a special cancer series. We're starting with lung cancer. Lung cancer is a tough cancer. It currently accounts for about 1 in 5 cancer deaths. But that figure isn't set in stone. We now better understand the dangers of smoking, and what's more, lung cancer treatment is getting better and better every day. Joining us today are Pulmonologist Dr. Bade and oncologist Dr. Konstantinos Leventakos. They're part of a power team delivering cutting-edge lung cancer treatment at Mayo Clinic, and they're here to share more about screening, treatment, and what gives them hope for the future. Dr. Bade, Dr. Leventakos, thank you for joining us today.
Thank you, Kristen.
Pleasure.
Before we dive in, let's get to know both of you better. Can you both briefly introduce yourselves and the role you both individually play in treating patients with lung cancer?
My name's Bade. I'm a pulmonologist and a critical care physician, and I treat predominantly patients with lung disease and lung cancer, often in the beginning of the lung cancer journey where somebody might have symptoms or we're evaluating or treating their lung disease or managing spots on the lungs.
I'm Dr. Leventakos, and I'm one of the thoracic oncologists specializing in the care of patients with lung cancer. Oncology is a subspecialty of medicine that focuses on the care of patients with cancer.
And you two work together. How do you work together specifically?
I think a most common scenario is somebody comes into our lung cancer clinic and they may have a concerning spot and they'll see me first. And I usually focus on lung disease, so evaluating someone's lung health or lung function. And then once we know that a spot might be cancer, then Dr. Leventakos or Kostas would see patients afterwards. In the last week, Kostas and I have seen patients together in clinic to try and address their lung disease and their cancer at the same time. And then we also have daily meetings where everybody on our lung cancer team discusses cases.
We all believe very strongly in the multidisciplinary nature of what we're doing. So we have formal meetings, but it is always a pleasure when I'm in the same room with Brett, taking care of the patient.
Now, let's talk about this from the patient perspective. When a patient is first walking into one of your offices, what are they usually telling you is wrong?
I think one of two scenarios are most common. One is somebody has a new symptom that caused them concern. The most likely of those is coughing something up, especially blood, wheezing, or fatigue. The other pathway would be if somebody's had some imaging of their lungs and they see a spot that we need to understand better what that is.
As an oncologist, I usually get into the journey of the patient when they are diagnosed. So we go over the initial symptoms, but most of the workup has been done by amazing colleagues who have come up with the diagnosis, and they have helped the patient navigate the diagnosis.
And lung cancer is often diagnosed late. Is it because patients initially just don't have very many symptoms, or the symptoms just look too much like other things, like, oh, it just feels like a seasonal cold? What exactly is causing people to not even realize that they might have cancer early on?
I should mention that the most common scenario is somebody has no symptoms. The lungs are pretty big organs, and if somebody has a small spot or a tumor, it might not come to our attention until that spot has grown to involve something else. That is something that causes a cough, something that causes pain, something that causes bleeding. We often don't find it until somebody comes to us with symptoms and a lung cancer has already spread to other organs.
When someone is diagnosed with lung cancer, what's typically been happening in their body up until that point?
Oftentimes, there's been several years of an exposure to the lungs that we may or may not recognize. So what's been going on in the lungs is often several years of inflammation from something. Tobacco smoking is the most common. Other lung conditions, for example, COPD or pulmonary fibrosis, both of which are lung conditions associated with inflammation and tobacco smoking. A chronic cough is common. What often brings patients to our office is if that cough changes or the content of what they cough up, not to be too gross, changes in color, or if they see blood in the sputum or the mucus they cough up.
You already mentioned, Dr. Bade, that smoking puts somebody at great risk for lung cancer. Dr. Leventakos, what are some other risk factors?
We know that smoking is the major preventable risk factor for lung cancer. But what I usually say is that one of the risk factors of having lung cancer is to have lungs. And we all have lungs, right? Air pollution is very important. We can call about 14% of cases of lung cancer being due to air pollution. Also chronic inflammation of the lungs, other type of infections. We start recognizing families that might have specific genetic mutations, but really we need more research on that. But I think for what is more actionable, avoiding anything that hurts our lung would be the most important thing for all of us to do.
And if I could add two to that list, the second that I'd want people to know about is actually radon. Radon is a colorless, odorless gas, often present in the basements of certain parts of the U.S. There are commercially available kits that you can buy pretty easily. It sits in your basement for a period of time, and you can send it off for testing. As Kostas pointed out, inhaled exposure of any smoke to your lungs, whether that's pollution, environmental smoke, occupational exposure.
Let's talk about screening for lung cancer. What exactly are you looking for in this screening, Dr. Bade?
So our goal with screening is to find lung cancers that are small and not causing any symptoms. And the reason we focus on that is we're much more likely to be able to cure a lung cancer if we find it early.
What are the reasons and the guidelines for testing people at this point?
So the most common one used in the U.S. recommends lung cancer screening in patients based on age, specifically patients between the ages of 50 and 80. And secondly, tobacco smoking history. And this one is a little bit of math, but the recommendation is patients with what they call 20 pack years, which is the product of the number of packs per day one smoked on average and the number of years one smoked. So it can be a small amount of smoking for a long period of time, or a large amount of smoking for a shorter period of time. And the last criteria is patients who currently smoke or quit within the last 15 years.
What does the screening procedure look like?
For lung cancer, you come into the radiology suite and we give you it's called a low-dose CT scan, which only takes a few minutes. So oftentimes the CTs have a machine that you lay down in, and you lay on a stretcher that slides you back and forth while the machine takes several x-rays so that we can see your lung in its entirety. It's not loud or prolonged like some people associate with, for example, an MRI. It's quiet, fast, and doesn't require any preparation before the scan.
Most of my patients tell me, why didn't I know about that earlier? There is no pain. There is no side effects that I know of. The radiation is very, very low. So definitely something that we are happy that we have as a tool.
That's
wholeheartedly agree, because the lung cancer screening is really important and works well. Only a small fraction of people who are eligible for lung cancer screening are undergoing the scan, even though it's easy and obtainable.
That's very reassuring for folks who might be a little anxious about a screening. However, is there a risk with screening that maybe false positives might come up or overdiagnosis?
Overall, I'd want to convey that the benefits are much higher than the risk. But To your point, what I tell my patients is actually more likely than not, we're going to find something in your lungs that we're going to have to talk about afterwards. Anywhere between around 25 or 60% of patients have spots on their lungs that we need to follow after that baseline scan. And even outside the lungs, that CT scan that we're talking about images you from the bottom of your neck to the top of your stomach. So we can see heart, lungs, blood vessels, liver, parts of the kidney. So it's common that we might see, for example, other lung disease, emphysema or scarring of the lungs, and most commonly heart disease, so calcifications on the arteries of the heart. So incidental finding is one of the risks that we should know about. The other is false positives. In the published studies, over 90% of the spots that we see are not cancer. We're probably going to find something that needs following, but most of the spots are not cancer. The other risk was radiation. We're very cognizant of how much radiation we give people because it's not a one-time exam. We want to image them at baseline and then at least annually thereafter. So we minimize the amount of radiation that someone receives, hence the low-dose CT. And the last I'd mention is overdiagnosis. There are spots on the lungs that may actually be early cancers, but grow exceptionally slowly. I often liken it to prostate cancer, where we may find it and not have to act on it, but instead monitor it once a year or so.
Are there times you might actually elect not to screen someone?
The answer is yes. So the two scenarios when you might not undergo screening are, one is if your age is no longer in the criteria, and the other is if you have other conditions that may put you at more risk for any of the evaluation we would do. For example, patients who need oxygen or get very short of breath. So we don't want to submit a person to a procedure or a surgery that might harm them.
That makes sense. Risks for lung cancer include anything that can harm your lungs. Smoking, air pollution, radon gas, and other environmental exposures are the ones we have the most control over. Other lung diseases, genetics, and anything else that causes chronic inflammation in the lungs can be risks as well. Many lung cancers aren't detected until they've spread to other parts of the body. That's because most people usually don't experience any notable symptoms until the cancer has already spread. That's why screening is so important. If you currently smoke, have a history of smoking, or are between the ages of 50 and 80, you're likely eligible for a lung cancer screening. The screening is fast, easy, painless, and requires zero preparation, so why not get screened? But screening and diagnosis is only the start of the journey. Let's talk about the next phase, deciding on treatment. Let's say someone has been diagnosed with lung cancer. Let's talk about the next step, which is staging. Can you walk us through the differences between stages 1 through 4 of lung cancer?
So we have a commonly used staging system where the cancer started in the lungs, how the cancer has involved possibly lymph nodes, and potentially there could be some metastasis, meaning spread outside of the lungs. And then we collect all this information and we come up with 4 stages. Stage 1 is usually limited in a small area in the lungs. Stage 2 can involve some of the lymph nodes. Stage 3 can involve a few more lymph nodes. And stage 4, which is what people usually get diagnosed with, is when the cancer has spread to other organs.
Let's talk about the treatment for each stage. How does it differ depending on, let's say, someone's in stage 1 versus stage 4 with their cancer?
The treatment of lung cancer is highly specialized and highly personalized, but definitely we use the stage to guide us to bring the right specialists into the care of the patient. So for stage 1, maybe surgery or radiation would be more than enough. For stage 2 and 3, surgery and radiation in combination with some systemic therapy and different combinations like treatments before surgery and after surgery, chemotherapy combined with radiation can be options. When it comes to stage 4, we know that the cancer has spread beyond the lungs, so usually it is some systemic therapy because we would like our medications to go all over the body.
I think lung cancer and lung cancer treatment carries a stereotype for a lot of people that if you develop it, there's not much that we can do about it, and your time might be limited. That's an idea that is several decades old now. Regardless of the stage, we have several options that are much more effective than they were 10, 20, 30 years ago. We'll talk about what we think would work best and then have a single path that is specific to that person.
That's very reassuring because I think a lot of people hear stage 3 or stage 4 and they think, well, this is hopeless. And you're saying that's not true. Anything we may have heard that was 100% doom and gloom 10 or 20 years ago, that's probably not the case now.
If I had to say something that is how much more hope we have right now. The treatments have changed. Every 6 months, we have new medications being approved. Lung cancer is not one size fits all. We see groundbreaking changes even in the most aggressive types of lung cancer. Every day, I am blessed to meet patients that have done so well for many years after they were diagnosed with metastatic lung cancer. And for some of them now, 10, 11 years, which is actually all my medical career.
That really is reassuring and inspiring. Let's break down some of the different options. Let's dig deeper into immunotherapy. What does that approach look like?
The way I explain to my patients is if I have cancer, I know that there is a bad guy in my system. The immune system is still there, but it doesn't do anything to recognize the cancer. And we found out that cancer has mechanism to hide from our immune system. Immunotherapy comes to wake up the immune system and unhide the cancer so that the immune system can go after the cancer. And many times, the way it treats the cancer makes patients live for years and years. I put no limits to what I expect immunotherapy to do, and patients really benefit from immunotherapy.
I got to say, immunotherapy sounds like magic. It's like putting night goggles on our immune system so they can see something that maybe isn't visible to them the rest of the time. And how do you decide if immunotherapy is a good option for one of your patients?
In general, it is very important that every patient with lung cancer has biomarker testing so that we know what is the appropriate treatment for them. And the biomarker testing can be looking for specific proteins in the cancer cells. We need to break down into the DNA of the cancer cells in order to identify the mechanisms that make the cancer cells grow and see if we have targeted treatments to stop the cancer from growing. So biomarker testing is something that can be done in the tissue preferably, but there are also blood tests that can be done in specific situations.
So somebody often sees me, we find a spot, we biopsy it. That's when we send that tissue off to the lab. You get a long report in that we can see what markers might tell us that your immune system might be able to fight and kill this cancer, or do we have medications that are specifically targeted to that type of cancer?
With immunotherapy, are there any side effects or concerning reactions that might show up with that treatment?
Most of the people will not have any side effects. There is a minority of patients who will have side effects, and fortunately, only very few people who will have very serious side effects. There are cases with immunotherapy where the immune system can go against normal tissue. Most of the side effects, one, we get alerted early that they're happening. We have good ways to treat them before they become very serious.
Now, let's talk about chemotherapy. What happens during that process? And why would a patient go down this route instead of immunotherapy?
Chemotherapy is a substance that is usually given IV, even though there are some forms of oral chemotherapy. They usually target the mechanisms of replications of DNA and the cells so that it stops cells from dividing and the cancers from growing. Chemotherapy can be used by itself. It can be used in combination with other medications like targeted therapies, and it can be also used in combination with immunotherapy. So I would take chemotherapy as one of our tools when we try to personalize treatment for the patient. Throughout the years, chemotherapies have been made in safer ways, and we also have improved the supportive medications. So many years ago, nausea, vomiting was a really big side effects of the classic chemotherapies. Now, for most of the patients, the experience of chemotherapy is much more tolerable than it was before.
That's reassuring. What about radiation? Why would that be a good fit for a patient?
We mentioned the importance of low-dose CT for lung cancer screening. The reason that's important is in high doses, X-rays injure cells. In radiation treatment, we want to give higher doses to kill cancer cells. So that's the basis of radiation. We can use radiation in any of the 4 stages. In early stages, high doses can be targeted to and kill an early stage cancer, whereas in higher stages, we might control it or try and control symptoms in an area where it's causing problems. For example, cough, coughing up blood, or pain in the bones.
Lung cancer treatment is highly personalized. That's because doctors can use cancer stage and biomarker testing to determine what treatment or combination of treatments will be the most effective. Based on that information, patients might undergo immunotherapy, chemotherapy, radiation, or some combination of treatments. And the list of new treatments is constantly growing. The current outlook for lung cancer patients is the best it's ever been. But can we go further? Let's learn more about what the future holds. I'd love to talk about the future of lung cancer. What innovations are being developed right now for lung cancer? Things you're really excited about or looking forward to?
So one is, if we were to look at early stage cancers, we're getting better at the surgery itself. And the stereotype from a lung cancer surgery is a very large incision and a long recovery time. We now know that there are many situations where we can do a much smaller surgery, where instead of one long incision, we're doing many small incisions and pull out a smaller portion of lung, which preserves lung function so that people don't have such a long recovery time and then no symptoms thereafter. And the other, historically, we knew that if you had a cancer, we were going to give chemotherapy if it had spread. We now know that we can combine all of these therapies, that is, surgery with chemotherapy, surgery with immunotherapy, surgery with targeted therapy, or chemotherapy with immunotherapy. If you look at the guidelines for lung cancer, it used to say for a stage, here's your one therapy. Now you have a list of things that are an option for an individual person's tumor. And it's really hard for even us in the field to keep up because from month to month, there's new medications, new combinations. And this is all good news because all of those therapies work better?
I would like to focus a little on clinical trials, how important they are, because this is the way to bring new treatments to our patients. And clinical trials are introducing the medications of the future. The advancements that I see are mainly new treatments, either new modalities or new medications that can give a bigger hit to the cancer with less side effects.
The one addition I'd want to make to things that I'm looking to the future is the idea of survivorship care. We're getting better at recognizing lung cancer early, and then when we find it, what we can do about it. As a result of that, patients are living longer. So what do we do to make sure that their life, their symptoms, their quality of life during and after their cancer care is better?
That's so reassuring to hear. I mean, now we're not just talking about life with lung cancer, we're talking about life after lung cancer. So how do you advise patients during that phase?
What I tell all of my patients, you're a cancer survivor, you live with cancer. Let me do what I know to do with my medications, our expertise. But I want you to do 4 things for me. Number 1, keep a good connection with your care team. Tell us everything, any new symptoms, any questions, something you want to double check. We are here for you. Number 2, eat well and healthy. Number 3, keep moving and keep exercising. And number 4, the most important, keep positive. And it is the same things that make all of us stronger every day. It shouldn't be different for our patients who live with lung cancer.
That feels like something that we can do. Are there any resources, doctors, that you'd like to point our listeners to when it comes to learning more about cancer care or about cancer itself?
The internet has so many resources. The most important thing is to be able to filter resources that we can trust. So I usually go for the National Cancer Institute, American Cancer Society, institutions like Mayo Clinic.
I think most of our listeners who have cancer are probably getting care at a cancer center. The cancer centers have abundant information. At Mayo Clinic, we have abundant educational resources. And then there are a lot of patient advocacy groups that work nationally, statewide, and even in an individual hospital. I would also emphasize that there's a lot of misinformation out there. So some guidance from your physician team, pulmonary, oncology, primary care to make sure that your sources are legitimate. But there's a lot of support out there that we can connect you with.
Here in Minnesota, we are privileged to have an organization called the Breath of Hope. They have a specific website called You and Lung Cancer. So I always tell patients there is so much good information and we are here to guide you.
Beautiful. Do either of you have any final words of wisdom you'd like to end with?
The only thing I'd highlight is anyone with lungs can get lung cancers. We're seeing more lung cancers in patients who never smoked. So that idea that if you don't smoke, you can't get lung cancer is not right. So I encourage patients to be cognizant of both their exposures and their symptoms because we have to be vigilant in it in everyone.
The big things that we don't want to forget. If we feel we need to get screened, and the most important thing, let's try to be kind to each other and bring more research and more treatments for those who need them.
Wow, Dr. Bade, Dr. Leventakos, this has been such, and I can't believe I'm saying this in a cancer conversation, an incredibly hopeful conversation we just had. So thank you so much for your expertise and also just the heart that you brought to this conversation.
Kristen, thank you for what you're doing.
Thank you also.
Lung cancer treatment has already improved by leaps and bounds, and that trend is likely to continue. Along with more personalized treatments, clinical trials are bringing new, innovative treatments to patients. And care teams are focusing more on quality of life throughout the journey, even to survivorship and beyond. And in the meantime, we can all do our best to stay healthy, take good care of our lungs, and if we feel like we might need to get screened, have that conversation with our doctors. Okay, that's all for this episode, but if you've got a question, a topic suggestion, or a follow-up question about this episode, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more Health Matters episodes and resources, head to mayoclinic.org/Health Matters. And if you found this show helpful, please subscribe and make sure to rate and review us in your podcast app. It really does help others find the show. Thanks for listening, and until next time, take care and stay healthy.